What is going on, everybody? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my cardiology playlist. In previous videos, we talked about angina, myocardial infarction, the types of shock, such as hypovolemic, cardiogenic, obstructive shock, septic shock, anaphylactic shock, and neurogenic shock. We talked about rheumatic fever and infective endocarditis, dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy, acute fibrinous pericarditis and constrictive pericarditis, as well as broken heart syndrome and cardiac tumors. We also discussed cardiac arrhythmias. Today, we'll start a new series on the valvular heart diseases, beginning with aortic stenosis. Stenosis means narrowing of which valve? The aortic valve. It's not that the aorta as a vessel is narrow. Instead, it's the fact that the aortic valve is narrow. So a more accurate description is aortic valve stenosis. Click the like button, click the subscribe button, and let's get started. This is my cardiology playlist. It has cardiac anatomy, physiology, pharmacology, and pathology. Get a piece of paper and doodle with medicosis. Okay, this is the left ventricle and this is the aorta. We have ascending aorta, we have aortic arch, and we have descending thoracic aorta. Just like that. The ascending aorta is going to give us two famous arteries. Do you know their names? This is the right coronary artery and this is the left coronary artery. The right coronary artery is going to descend like this. It's going to wrap around the right border of the heart, and then you'll find it behind, and it will continue downstairs as the posterior descending artery. This is true for many, but not all people. This is called the right dominant circulation. As for the left coronary artery, it will divide into two very famous arteries. One is called the left anterior descending artery, also known as the widow maker. It's the classic story of the old guy dying from a clot in the left anterior descending artery, leaving his wife as a widow, hence the widow maker. And then the left coronary artery is going to give me what else? The left circumflex artery, just like that. Name the artery that supplies the inferior wall of the heart. In most cases, it's the right coronary artery. This is called the right dominant circulation. Name the artery that will supply the anterior wall of the heart. This is the left anterior descending artery. And please name the artery that will supply the lateral wall of the heart. It's the lateral circumflex artery. That's it for the ascending thoracic aorta. Then we have the aortic arch, which has three famous branches. Here is one, here's the second one, and here's the third one. You have to know them in order. Look, if I ever show up to your hospital with a stab wound traversing my chest, before I let you touch me or treat me, I'm going to ask you, Doctor, what are the three branches of the aortic arch? If I do not get my answer in 3 seconds, I will decline treatment. I would rather succumb to my open wounds than be treated by a schmuck who does not know the three branches of the aortic arch. This is unacceptable behavior. The three branches are brachiocephalic artery, left common carotid artery, and left subclavian artery, in this order from proximal to distal. And then this brachiocephalic artery, let's draw it right here, is going to divide into subclavian artery on the right side and right common carotid artery. And then the right common carotid artery will divide into right external carotid and right internal carotid arteries. So please note that the left ventricle is connected to the aorta and the aorta is connected to the carotids. And that's why in aortic stenosis we can hear a murmur over the aorta and it will propagate or radiate to the carotid. If you wish to see more videos like this in the future, drop a heart emoji in the comments. Here's the aortic arch again, brachiocephalic, left common carotid, left subclavian. And then the brachiocephalic divides into right subclavian and right common carotid. Here's the brachiocephalic artery dividing into right subclavian artery and right common carotid artery. The right common carotid artery dividing into external carotid artery and internal carotid artery. The right subclavian artery continues as the right axillary artery in your smelly axilla. Then right brachial artery, then it divides into radial artery and ulnar artery. Then the aortic arch becomes the descending thoracic aorta. Then this descending thoracic aorta is gonna pierce the diaphragm. At which level does the aorta pierce the diaphragm? Is it T1, T3, T10, T12, T8, or what? If you know the answer, please comment below. This is the abdominal aorta, which takes care of your kidneys, your adrenals, your gut. The artery of the foregut is the celiac trunk. The artery for the midgut is the superior mesenteric artery, and the artery for the hindgut is the inferior mesenteric artery. Then the abdominal aorta ends by dividing into right common iliac and left common iliac arteries. Each common iliac artery will subdivide into external iliac artery and internal iliac artery. The external iliac artery will give us the deep circumflex iliac artery and the inferior epigastric artery, which will then anastomose with the superior epigastric artery, which is a terminal branch of the internal thoracic or internal mammary artery. Then the external iliac artery disappears deep to the inguinal ligament, which stretches from the anterior superior iliac spine to the pubic tubercle. The external iliac artery changes its name thereby into the femoral artery, which will give us the profunda femoris artery or the deep femoral artery, which is the main artery of the thigh. Then the femoral artery disappears behind your knee and changes its name to the popliteal artery. There was more anatomy in the last 5 minutes than you have learned in an entire 2-month period. If you want more medicosis anatomy in your life, check out my anatomy playlist on YouTube. I have review videos for the anatomy of the head and neck, anatomy of the upper extremities, lower extremities, anatomy of the thorax, the abdomen, the pelvis and perineum, neuroanatomy, and embryology. Each one of these topics is covered in 3 different videos. For example, part 1 of the thorax is called quick review, part 2 of the thorax is ultimate review, and part 3 is clinically oriented anatomy of the thorax. And we repeat the same process for each subject. Back to the heart, let's talk about the 4 chambers: right atrium, right ventricle, left atrium, left ventricle. Let's talk about the valves. Between the left atrium and the left ventricle, we have the mitral valve. Between the right atrium and the right ventricle, there's the tricuspid valve. Between the left ventricle and the aorta, there is the aortic valve. And between the right ventricle and the pulmonary artery, there is the pulmonic valve. The left ventricle, as you see, has a wall, okay? And it has a cavity. And it has an outflow tract. We call this the left ventricular outflow tract. And then after that, you have the aortic valve. So in order, we have the left ventricular cavity, left ventricular outflow tract, and then the aortic valve and the aorta. So here are the 4 valves: aortic valve, mitral valve, pulmonic valve, tricuspid valve. Each one of them can be narrow. We call that stenosis, which is difficulty opening because it's narrow. Imagine that your door frame got narrower. It was wide open before, like this, but now it's narrow, like this. So, when you want it to be wide open, now it can't. It's difficulty opening. How about aortic regurgitation then? No, regurgitation means it was supposed to close like this, but instead of closing, it remained open. This is failure to close or difficulty closing, and we call this regurgitation. So we have aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation, pulmonic stenosis, pulmonic regurgitation, tricuspid stenosis, and tricuspid regurgitation. Today we're talking about aortic stenosis. We're going to cover all of these in subsequent videos in this cardiology playlist. Here's the cavity of the left ventricle. This is the left ventricular outflow tract. Then the aortic valve, then the aorta itself. Now, what if my aortic valve has stenosis, which means narrow? Oh, the valve is narrow, so therefore what? It is very difficult to push the blood from the left ventricle to the aorta because the door is narrow. That's why the left ventricle will have to try harder. Try again. Until the ventricular muscles get very thick. And we call this left ventricular hypertrophy. It's an enlargement of the left ventricle, but it's not that the cavity is getting wider, it's that the muscular wall is getting thicker. This is just like lifting weights at the gym. The more you lift, the thicker your muscles. So the aortic stenosis increases the afterload on the left ventricle. The left ventricle has to try harder, which causes left ventricular hypertrophy. This also increases the oxygen demand on the left ventricle, which is not good. What is the type of this ventricular hypertrophy? Is it eccentric hypertrophy or concentric hypertrophy? The answer is it is concentric hypertrophy. But what's the difference? Here is your normal heart. This is a cross section. Left ventricle is here, which is way bigger than the right ventricle. This is the left, this is the right. And all of this is normal. Eccentric hypertrophy is when the cavity gets wider, but not the wall. But that's not the one that we see in aortic stenosis. Instead, we see concentric hypertrophy, where the muscle wall is getting thicker, not the cavity. What causes eccentric hypertrophy? Volume overload, too much fluid. But what causes concentric hypertrophy? Pressure overload, too much pressure. When there is more volume being received by the heart before it contracts, we call that the preload. But when there is too much pressure facing the heart after or at the moment of contraction, we call it the afterload. In the next video, we'll talk about aortic regurgitation. Oh, this is backflow, more volume flow. Similarly, mitral regurgitation has the same problem. And because these cause volume overload, we expect eccentric hypertrophy. Today we're talking about aortic stenosis, which is a stenotic murmur. There is increased pressure. It's a pressure overload. There is increased afterload. In eccentric hypertrophy, we expect to hear S3 heart sound because of the volume overload. But in concentric hypertrophy, expect S4 heart sound. The normal heart sounds are only S1 and S2. S3 and S4 are mostly abnormal. How did the heart end up like this? Because we added sarcomeres in series. Instead of the muscle wall looking like this, now it looks like this. So there is longer muscles, so to speak. But in concentric hypertrophy, we added the sarcomeres in parallel. And that's how you end up with a concentrically hypertrophied heart. The heart that looks like this with eccentric hypertrophy is usually good at diastole, because look at all of this cavity, but bad at systole. The muscles are thin and stretched. However, in concentric hypertrophy, the heart is very good at systole. The contractions are robust, but it's bad at diastole. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. So what happens in aortic stenosis? Let's doodle together. Alright, the aortic valve is narrow. So therefore what? Well, therefore there will be less blood flow to the aorta. And this is something that confuses many students. Whenever the valve is narrow, the flow decreases, but the speed of the blood increases. Most students confuse the two. Pay attention. What is flow? What is love? Flow is volume over time. Okay. Now, if the valve is narrow, there will be less volume passing through the valve. And when the volume is low, the flow is low. So therefore, aortic stenosis decreases the blood flow in the aorta itself, and therefore there will be less blood going to the coronaries, the brachiocephalic, left common carotid, and left subclavian. But when it comes to the speed, it's a totally different story. Remember, it was A1V1 equals A2V2. From here, we can deduce that the area and the speed are multiplied by one another, so therefore they are inversely correlated, which means as the valve gets narrower, the area decreases and the velocity increases. So even though there is less blood flow in the aorta, that blood is flowing fast with vengeance. The decreased blood flow has clinical consequences, and the increased speed also has clinical consequences. What are the consequences of decreased blood flow? Well, there is decreased blood flow to the coronary arteries. So the patient suffers from chest pain upon exertion, also known as exertional angina. How about less flow in the brachiocephalic, left common carotid, and left subclavian? There will be less blood flow to the vital organs of the body, including the brain. This patient will suffer fatigue, pre-syncope, sometimes even syncope. The pulse pressure will decrease because pulse pressure is systolic minus diastolic. And when there is less blood flow in the aorta, the systolic blood pressure will decrease, and therefore the pulse pressure will decrease as well. Because the valve is narrow, it takes longer for the same volume of blood to reach the carotids. So the pulse will be small and delayed. What is the Latin terminology for this? It is called pulsus, which means pulse. Parvus, which means small. That's why parvovirus is called parvo, because it's a small virus. Atardus, which means delayed. Next, what are the consequences of increased the speed of the flow? Well, if you put your hands on the patient's carotid, you will feel a thrill. Moreover, this increased speed, this vengeance by which the blood flows after the aortic valve causes the aorta to get wider. And we call this what? It's just a beautiful name. It is called post-stenotic aortic dilation. It's giving me daddy. Then, thanks to the increased afterload, the left ventricle will compensate by becoming thicker, and this is the concentric left ventricular hypertrophy, which increases oxygen demand. In severe late cases, this can lead to left-sided heart failure, which is not good. When the left side fails, expect to find lung problems. Why? Because when the left side fails, all of that blood will accumulate in the left atrium and then into the pulmonary veins and then in the lungs. So I will get lung congestion. I'll get pulmonary edema, interstitial edema, alveolar edema, pleural effusion, cough, dyspnea, paroxysmal nocturnal dyspnea, orthopnea. Because this is coming from a wet lung that has lots of blood backing up, this cough will be productive cough and not dry cough. The sputum is usually pink and frothy. Why pink? Because there is blood in the lungs. Why frothy? Because there is air in the lungs. See, medicine makes so much sense once you understand what the French toast you're talking about. And sometimes it's not just cough that is tinged with sputum that is pink and frothy. Sometimes it's severe enough to cause frank hemoptysis. In the future, if I ever have a son, I will name him Frank Hemoptysis or Frank Necrosis. Next, since this left ventricle is thicker, we'll find that the left ventricular pressure is higher than normal. Now, what do you think is going to happen to the left ventricular end systolic volume? What is end systolic volume? It's the volume in the left ventricle at the end of systole, after the ventricle contracts. Well, after the ventricle contracts, less blood is gonna leave to the aorta, and therefore more blood will remain in the ventricle. And that's why the left ventricular end systolic volume will also go up. So the left ventricular pressure goes up, and the left ventricular end systolic volume goes up as well. Why is this important? Does anyone remember the pressure volume loops? If you want to brush up on this topic, please refer to my cardiology playlist. I have a video titled Cardiovascular Physiology and the pressure volume loops. So there is the left ventricular volume on the horizontal axis and left ventricular pressure on the vertical axis. First, let's draw the normal. The normal looks like this. Okay, that's amazing. And please keep in mind that this right here represents the left ventricular end diastolic volume, and this line right here represents the left ventricular end systolic volume. Now, what do you call the difference between the EDV and ESV? End diastolic volume minus end systolic volume is the stroke volume. And this is systolic pressure, this is diastolic pressure, not in the artery, but in the left ventricle. The systolic pressure in the left ventricle during systole is 120 millimeters of mercury, and the diastolic in the ventricle is not 80, it is 0. All of this was normal. Now let's see what's going to happen in cases of aortic stenosis. Oh, look at that. So the diastolic blood pressure is not going to change, but the systolic is going to increase a lot. Why? Because the ventricle is contracting harder, because it's thicker, because the valve is narrower. So you'll find increase in the systolic blood pressure of the left ventricle. Okay, how about the end diastolic volume? It does not change, because it's the same left atrium giving the same amount of blood or the same volume of blood to the same left ventricle. What does go up, however, is the left ventricular end systolic volume. So instead of here, we're going to shift to the right and go here because the volume is increasing. And I'm going to draw the graph like this. And this is how normal looks like, but this is how aortic stenosis looks like. What can we observe? The systolic blood pressure is higher. The left ventricular end diastolic volume is higher, and the stroke volume is shrinking. It used to be all of this volume, now it's just from here to here. So there is decreased stroke volume. So in aortic stenosis, we expect increased left ventricular pressure, we expect increased left ventricular end systolic volume, and therefore decreased stroke volume. In mild cases of aortic stenosis, there is no change in the end diastolic volume. There is concentric hypertrophy of the left ventricle, which decreases ventricular compliance. Next, let's talk about the graph that has blood pressure here and time on the horizontal. Okay, let's go. Now, what is normal? Normally, the left ventricular pressure goes up to 120 systolic down to 0 diastolic. But the normal pressure in the aorta, yes, it goes up to 120 during systole, but it decreases to 80 only, not to 0 during diastole. just like that. And if you are super sophisticated, there is a dicrotic notch or incisura right here. To learn more about the notch, please watch my physiology playlist. All of this is normal. The pressure of the left ventricle normally, and the pressure of the aorta during normal circumstances. Systolic is up, diastolic is down. Now, what's going to happen during aortic stenosis? Well, the poor left ventricle will have to fight harder. It will hypertrophy, and it will push the blood with vengeance. So now, the left ventricular pressure goes up like this. Oh, look at that. It is still descends to 0, diastolic, but it goes up to, let's say, 150, systolic. Under normal circumstances, the systolic blood pressure in the aorta equals the systolic blood pressure in the left ventricle. But if I have aortic stenosis, please note that the left ventricular pressure exceeds the aortic pressure during systole, and this is important. If it's aortic stenosis and we have concentric hypertrophy in the left ventricle, do you expect S3 heart sound or S4? The answer is S4 gallop. Here's the normal S1, here is the normal S2, and there is the next S1 of the following cycle. Between S1 and S2, there is systole. Between S2 and the following S1, there is diastole. Where should I put this abnormal S4? Just before S1, like this. What causes the normal S1? Closure of the mitral valve and the tricuspid valve. They close together. What causes S2? The closure of the aortic valve and the pulmonic valve. They do not close exactly together, but close enough. There is a normal gap between them. We expect A2 before P2, but that's a story for another time. Let's put a stethoscope on the patient's heart and hear the murmur of aortic stenosis. How does it look like? It looks like this. It goes up, crescendo, and goes down, decrescendo, usually preceded by an ejection click. Moreover, recall that the S2 is made of A2 followed by P2. Normally, A2 is heard before P2. But in cases of aortic stenosis, because we are overwhelming the left side, guess what's going to happen? This A2 will be heard after P2. And what do you call this? Well, this is a paradox. So we call it paradoxical splitting of the second heart sound. Instead of A2, P2, now we hear it P2, A2. This is the first aortic area. This is the second aortic area. This is the pulmonic area. This is the tricuspid area. This is the mitral area. It's A, P, T, M. A, P, T, M. Where do we hear the murmur of aortic stenosis? We hear the murmur of aortic stenosis in the aortic area or the first aortic area, which is the second right intercostal space, very close to the sternal border. And this is where you hear the murmur of aortic stenosis. Crescendo, decrescendo murmur during systole, not diastole, sometimes preceded by an ejection click. Why is the aortic stenosis murmur systolic? Well, remember, what's the definition of stenosis? Stenosis is a valve that is narrow. It cannot open. And when is the aortic valve supposed to open? Is it during systole or during diastole? The answer is the aortic valve should open during systole to allow the blood to flow from the left ventricle to the aorta. Failure to open, aortic stenosis, will also happen during systole. That's why the murmur of aortic stenosis is systolic. S1 is here. S2 is here. Between S1 and S2, this is systole. Between S2 and the following S1, this is diastole. From S1 to S2, we have this aortic stenosis murmur, which is crescendo, decrescendo, systolic of course, and preceded by an ejection click in some cases. Here is everything you need to know about aortic stenosis in one slide. Aortic stenosis is the most common valvular heart disease in industrialized nations. However, in developing countries, because rheumatic fever is common, mitral valve diseases will be more common. Some patients have aortic stenosis and aortic regurgitation together. We call this double aortic valvular lesion. Old age is a risk factor because with old age, I get dystrophic calcification and fibrosis of the aortic valve. Normally, the aortic valve has 3 cusps. It's tricuspid. However, in some patients, they are born with 2 cusps only. A bicuspid aortic valve can lead to aortic stenosis. Rheumatic fever is a risk factor as well, especially chronic rheumatic fever. Aortic stenosis increases the afterload, so therefore the left ventricle has to pump harder This causes hypertrophy of the left ventricle. Is this hypertrophy concentric or eccentric? The answer is concentric. This hypertrophy of the left ventricle increases oxygen demand and decreases ventricular filling during diastole. Why is this? Because the wall of the left ventricle got thicker and the cavity of the left ventricle became narrower, which decreases ventricular filling during diastole. Eventually, in severe cases, this will lead to left-sided heart failure. And left-sided heart failure will overwhelm the pulmonary circulation, which will overwhelm the right ventricle. And before you know it, I can develop right-sided heart failure after the left. And this is a very important point. Left-sided heart failure can cause right-sided heart failure. But the opposite is almost never true. It is extremely unlikely to start with right-sided heart failure, and then because of that right-sided heart failure, you end up with left-sided heart failure. It doesn't work like that. It goes from left to right failure, but not the other way around. You know what else? Well, the coronary arteries fill during diastole. That's normal. But because the ventricles did not fill as much because the wall is so thick, therefore the coronary flow will decrease during diastole as well. That's not good. That's why we get chest pain and exertional angina. Next, because the aortic valve is narrow, less blood will reach the aorta, leading to low cardiac output and the symptoms of low cardiac output. What are these symptoms of low cardiac output? They include symptoms in the CNS, such as dizziness, headache, and syncope. Symptoms in the CVS, cardiovascular system, such as ischemic heart disease, the angina, and in severe cases, myocardial infarction. Blood pressure will drop if the cardiac output is low, because remember, blood pressure equals cardiac output times total peripheral resistance or systemic vascular resistance. That's why if the cardiac output is low, the blood pressure will be low. More symptoms of low cardiac output include fatigue, weakness, oliguria, because without enough perfusion, your kidney is toast. The skin becomes cold with peripheral cyanosis. Skeletal muscles have fatigue and intermittent claudications. Exertional dyspnea, meaning shortness of breath upon exertion, not during rest. Syncope or pre-syncope, low pulse pressure, S4 gallop or S4 heart sound. Pulsus parvus et tardus. The pulse is small and the pulse is delayed. So, if the normal pulse should look like this, up and down, the small delayed pulse will look like this. It is slowly rising and then descends like that. You can feel a thrill on the carotids. You can hear a murmur in the first aortic area, which is systolic crescendo decrescendo ejection murmur, preceded by an ejection click. How can we diagnose aortic stenosis clinically? And when you hear a murmur with a stethoscope, the question on the exam is going to ask you, what is the next best step, or how do you confirm the diagnosis? The answer is echo. When you hear the murmur, the next step is to do an echo, such as transthoracic echo or transesophageal echo. If we do an EKG, we might find the signs of left ventricular enlargement. Chest X-ray. In severe late stages of aortic stenosis, you can see the calcifications in the aortic valve on chest X-ray. You might even see the left ventricular enlargement and the post-stenotic aortic dilation that happens after the stenosis. If you want the most accurate test, although not necessary in many cases, it's cardiac catheterization. How can we manage aortic stenosis? We have medical management and surgical management. Medical, ACE inhibitors and beta blockers, because it's a pressure overload. And then surgical, such as aortic valve replacement and repair. Some patients need antithrombotic therapy after the surgery. Here's a question for you. When should we treat aortic stenosis? The answer is when it becomes symptomatic. What's the difference between repair and replacement? Repair, you repair the valve in place, but replacement, you remove the old one and you put a new one. The new one could be a tissue valve, e.g. from a pig, or an artificial metallic valve. You can actually know whether the patient has a metallic valve in or not just by auscultation. You will hear the metals touching one another. To learn more about ACE inhibitors, beta blockers, calcium channel blockers, the antiarrhythmics, the antihyperlipidemics, antihypertensives, anti-anginal medications, the diuretics, and digoxin, download my cardiac pharmacology course at medicosisperfectionalis.com. To learn about transient ischemic attacks, stroke, myocardial infarction, angina, the cardiac arrhythmias, ARDS, the toxidromes, and more, download my emergency medicine high yields course at medicosisperfectionalis.com. And to learn about cardiothoracic surgery, vascular surgery, neurosurgery, orthopedic surgery, general surgery, trauma surgery, download my surgery high yields course at medicosisperfectionalis.com. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.